Thank you so much for the chance to be here. My name's Jeff Brenner. I'm a family doctor. Used to run the Camden Coalition of Healthcare Providers and work at United Healthcare now. I've been there for about 14 weeks. I'm the Senior Vice President for Health and Integrated Social Services, which is a very daunting title, right? I want to express a huge amount of appreciation to the team that put this together. It's an incredibly daunting topic. It's a huge body of ideas to put together into a coherent narrative, and you guys did an incredible job. What I like best about the report, and I think you alluded to this a few times, Peter, is that it's also a humble report, which is there's just a lot of stuff that we don't know yet, and the report doesn't claim more territory than we've got, and I think that's important. I also, there were reports back in the 80s and 90s about complex patients, so this is like we have been here before. So I do think it's really important. As I read this report and think about the field and keep checking in with all my colleagues, we're in a 30-year arc. It's going to take a long time to figure all this stuff out. So we're also in a race against time as baby boomers are aging, retiring, and falling apart, and costs are going to begin to escalate. So I both want to acknowledge there is a crisis that will rapidly emerge, but also that we want to make sure we have dialogue, particularly in environments like this, about how we build for the long haul. And what are the structures that we need to put into place that will make this, instead of a 30-year arc, a 20-year arc, or make the next generation's work less daunting than my generation and the generation before. This has been tiring work for a lot of the people who've been out on the front lines of this. I want to make a couple of points. My favorite article published in the literature is one called The Ecology of Health, and I kept wanting it to appear in this report. So this isn't a critique of the report, but I want to sort of pull out this article and talk about it for a sec, because I think it's super relevant to the issue of taxonomy. So this was a study done back in the 60s and 70s and then repeated in 2001 by the Graham Center. And they looked at 1,000 people in a typical month and their behavior within healthcare. And if you take 1,000 people in a month, 800 report symptoms, 327 consider seeking care, 217 of the 1,000 go to a physician's office, 113 visit a primary care provider, 65 visit an alternative or complementary provider, 21 visit a hospital outpatient clinic, 14 receive home health care, 13 visit an ER, 8 are hospitalized, and less than 1 are hospitalized in an academic health center. We spend all of our future healthcare professionals train in that less than 1 of that 1,000 in the academic health center. So they see a little tiny portion of this whole ecosystem. But what's fascinating about this is to think about who moves from one boundary to another. Of the 800 people who had symptoms, only 300 considered seeking care. What was going on in the mind of the other 500 who immediately wrote it off and said, I didn't need care? And of the 113 that went to a primary care office, how did they sort themselves out? Who are the counterfactuals, the other 700 that didn't go to a primary care office? Way down to the 13 that visited an ER, what about the 987 who didn't go to an ER? Like, who's moving across these boundaries, and the sorting process is really a taxonomy question. There's something about the taxonomy of how people are sorting themselves out that we haven't done enough work on. There is literature that looks at who seeks care and care-seeking behavior, but there's a lot of dead ends in that literature, a lot of work that was never followed up on, and a lot of work that could be done. The other thing that we need to clarify, and we use these words interchangeably, and anyone who works in this field wrestles with this all the time, is clarifying utilization and cost. And lots of folks know someone can be high utilizing and low cost, high utilizing and high cost and low utilizing. It's kind of a 4-box. So what's our primary target? Is our primary target cost, or is our primary target utilization? And really, cost is a secondary. If cost was your primary target of all this, you would end up with a much bigger bucket of stuff that you're messing with. Like, you'd end up with, what's the cost of a hip, and what's the cost of that device, and what's the cost of the drug? If you're focused on utilization, you're going to end up in a very different bucket of work with very different problems that you're tackling. So I think whatever the movement we're in, I think our movement is about utilization as one driver of cost. So cost is price times utilization. Price is a valid target. Utilization is a valid target. I think this part of the movement to deliver better care at lower cost is utilization. There are other very valid work going on about price and other things, but I feel like we need to have a lot more discussion about that because we kind of lump it all together and wash over the contours of this. The other thing that's really interesting we don't talk about is super underutilizers, right? So we very much focused on overutilization, but actually it's even more interesting. Anyone who's ever practiced will describe literally the guy who is on their last leg has had their 4th heart attack sitting at home and didn't go. I mean, it's almost remarkable how bad they look when they finally get there. They finally collapsed and their wife called, and even as they're laying there half conscious, they're saying, don't call the emergency room, don't call 911. So there's sort of a 4-box of the evidence base for something and then whether or not it's necessary or not. So there can be no evidence for it, but a person have a need and therefore we have no treatment. They can have a high need and a high evidence, and that's a high value. But we haven't really sorted out sort of this whole range from overutilization all the way to underutilization, and it's really about sorting. So our goal isn't to lower utilization, it's to right-size utilization. We also want to increase utilization for the underutilizers if they're not getting an evidence-based treatment that they need. We also use really messy words around segmentation and stratification. So the problem with stratification is that you can't give one number to every sick person. Lining up everyone who's sick from tallest to shortest is sort of a fool's errand. So you would probably segment first, get people into a clear bucket, and then within that bucket you would prioritize through stratification techniques. So there's a way in which we're lumping all these words together without a lot of clarity. We also don't tend to be real clear about ER use and inpatient hospital use, and they're totally different phenomenon with very different drivers and very different populations. So these are really points about taxonomy. And one last point on taxonomy is with regression to the mean, a wonderful paper that Denver did about folks that regress to the mean. The gist of their article was that persistent high utilizers are a valid target for these interventions, but folks that naturally regress to the mean, we should just leave them alone. I actually think it's a taxonomy question, which is if someone progressed and then regressed, they should have never progressed in the first place, right? I mean, that's really telling you something about someone's underlying need. Both are valid targets for reducing utilization. You would presumably cut the area under the curve and reduce the acceleration of need, the length of need, and the cost of the need for the folks that are accelerating and then regressing. And for folks that are persistent, you would end up working with them as well. So both are valid targets. They just require different data models and different interventions. So I think there was sort of a faulty conclusion that we shouldn't work with folks that naturally regress to the mean. I think both are valid targets. So let me stop there. Thank you.
Jeff, thank you very much. Raina?